Good morning, everyone, and wishing you all a very happy New Year with my behalf and on parties of Microbiology. So, as Madam has already informed, that today we will discuss Antibiogram of Frequently and infrequently isolated bacteria. So, as you all know, antibiotics is a global threat, and empirical antibiotic therapy you all have to give. It's very important and depends upon the local epidemiology. So, this CGR has to be divided into 3 parts. One is what Dr. Akshay will discuss about an emerging pathogen, that is Microbiology, which is very important and called life-threatening infection. So, their isolation rate, what are the antibiotics, sensitivity patterns which we have, all that, what can be accurate, all that we did. Next, we will have a look at the isolation of emerging pathogens or uncommon pathogens, which many of the names probably do not even heard of. But we are isolating them, and it's very difficult to isolate them because routinely by routine methods cannot. We need special methods like multi-drop for this we have. That's why we can diagnose them. Otherwise, routine labs we don't have multi-drop or other high-end instruments, they cannot detect. But they are also very important, and we are isolating them in increasing number and from various types of from serious infection. So we thought it is apt to discuss them, their isolation rate and their sensitivity pattern. And lastly, as we do from time to time, whatever the samples we receive from various boards and ICUs, their isolation rate, what are the organisms we isolate, what are their sensitivity patterns, right? So that all that we will discuss. Because of the lack of time, this time we will discuss by board-wise, that various boards and what are the sensitivity pattern and isolation rate. But as you know, we publish newsletters time to time where we discuss it infection rises from various departments, what are the infections, and because it is very important to decide like API infection or TPS or in like when the patient comes, you have to decide what to do. So that this time will not be due, but we are working on it, and probably that will publish in forthcoming news. So with this, I would like to request Dr. Akshay to please start with it.
Thank you, ma'am. Myself, Dr. Akshay Arya, Senior Resident, Department of Microbiology. I will think the trends of bacteremia caused by Burkholderia syndrome. Coming to the introduction part, I will be describing the increasing trend of the incidence of bacteremia for the Burkholderia syndrome in the month of November. To start with, Burkholderia syndrome is aerobic gram-negative non-fermented bacteria was frequently isolated from the water environmental surface. It can survive in fluid, antiseptic solution, and in the healthy environment for long. Burkholderia syndrome is a slow viral organism, but in immunocompromised patient, it is affected with a poorer outcome rate. So how it was started? Before November, blood culture positive rate for Burkholderia syndrome for our center for average 3-month period was around 7.1%. On November 9, 5 out of 8 positive blood culture bottles were identified as Burkholderia syndrome. 2 samples were from hematology ward and endocrine surgery, and 1 from the emergency. Now we're performing the antibiotic sensitivity of this 5 isolates. We found a very interesting thing that all these isolates were having the exactly same antibiogram for the drug which were tested. Like Coagulase acid was 100% resistant to all these isolates, and other drugs like ceftazidime, chloromphenical, levoflox, cotrimoxazole, minocycline were found to be sensitive. So, exactly same pattern was found, and Coagulase was resistant to all these acids. Now, if we compare the positivity rate for the past 3 months for the Burkholderia syndrome, the month of December, we found that for the past 3 months it was 7.1%, but it rose to 26.8% in the month of November, again declined to 13.1% in the month of December. Now if we see from where these isolates were isolated, so we found that most of the isolates were isolated from the hematology ward, which was around 50%. 20 isolates were isolated from hematology ward, followed by endocrine surgery, it was 8, and emergency 6, followed by other wards like CCM, anesthesia, plastic surgery, pulmonary medicine, surgical care. Compared to the month of December, although the number of cases decreased from 40 it goes to 90, but we noticed that the isolation of the ward increased from 6 to 11. Now, what was more concerning was the change in the antibiogram pattern. For the first 7 days, it was isolated like from 9th of November to 16th of November, within the 7 days, the antibiogram panel showed that for 21 isolates, decarbonylic acid was resistant to all the isolates, and meropenem was resistant to 38% of the isolate. Was T. And the resistance of the isolate for meropenem, it was T, was from hematology ward, T from hematology ward, for emergency endocrine surgery for the first 7 days. Now, if we compare this change in the antibiogram, after within the first week, we have seen that within the 7 days only, the meropenem resistance rose to 100% only. From 38%, it rose to 100%. And for the decarbonylic acid, which was 100% resistant, to isolate found to be sensitive. So there was a rapid change in the sensitivity pattern of these isolates for the meropenem drug. Now for the next 15 days, the isolation for the resistance strain were also found other wards. It rose from 3 wards to 6 wards. So new wards were surgical gastro, pulmonary medicine, and plastic surgery apart from hematology ward. Now comparing, this was for the month of November. Now if we compare this pattern with the month of December, the December month, decarbonylic acid was again found to be resistant to all the isolates, and meropenem continued to be resistant, 100% resistant to all the isolates. Other than that, ceftazidime, chlorphenicol, levoflox, potrimazole, and minocycline were found to be 100% sensitive to all these isolates, which was seen in the month of November also. But what was there? For the month of December, from comparing to the 6th ward which were isolated, when meropenem was isolated, resistance strain, it increased to the 11th ward. New ward like neurosurgery, COVID-19 screening, and neurosurgery ward, immunology ward were added. So from 6 to 11 ward, resistance strain were found. Coming to the mortality part, out from the 59 cases, 6 mortality were reported for this period. 5 were reported in the month of November, which was from 3 from emergency, 1 from CCM, and 1 from hematology ward. In the month of December, 1 mortality was reported, which was from the surgical gastroenterology ward. To conclude, we found that there was an increase in number of bacteremia caused by Burkholderia Staphylococcus. Most number of cases were isolated from the hematology ward. Within a week, resistance to meropenem increased from 38 to 100%, and the number of wards in which these isolate resistance to meropenem were found were also increased from 6 to 11. Thank you. Now I would like to invite Dr. Linezolid ma'am, Assistant Professor, Department of Microbiology, for her presentation. Thank you.
Thank you, Dr. Akshay, and good morning to everyone. I'm Dr. Linezolid, Assistant Professor in Department of Microbiology. I'll be presenting the data on rare gram-negative pathogens which we identified in the bloodstream infections during the last 1 year. So we all know that gram-negative bacteria are now becoming leading causes of bloodstream infection. When we identify these gram-negative bacteria, we classify them on the basis of fermentation of a particular sugar called as lactose. So there are certain bacteria, gram-negative bacteria, which ferment lactose, and then there are others which do not ferment lactose. Lactose fermenting bacilli are E. coli, Klebsiella, which you all have heard of, and there are non-fermenting bacteria like Pseudomonas and Acinetobacter. These are important pathogens. Then there are certain other bacteria which are still non-fermenting, but they are other than Pseudomonas and Acinetobacter species. These infections now are increasingly being isolated, and these infections pose a challenge in both diagnosis and treatment. Why diagnosis? Because they are very difficult to identify by routine biochemical methods or traditional methods. So we need MALDI-TOF for the confirmation, which we have in our lab. Next, they pose a challenge in treatment also, because these particular non-fermenting gram-negative bacteria are intrinsically resistant to many common antimicrobials, for example, beta-lactam and colicin and even carbapenems. So correct identification and knowledge of the antimicrobial sensitivity patterns of these pathogens becomes important in a hospital to decide upon the empirical therapy and to decide upon what not to give out. So this is a list showing various uncommon gram-negative bacteria which we encounter during some bloodstream infection. As you can see in the chart, that majority of these isolates belong to both Coagulase species, which is around 53.1% among the rare isolates, followed by Staphylococcus maltophilia, followed by Serratia, Aureus, Aeruginosa, Linezolid, and Elizabeth species. All the gram-negative bacteria which I just mentioned are bacillus. They are rod. As you can see in the picture, they are all gram-negative, which means they show pink color when they change to gram. They are all lactose non-fermenting, and they all give a test which is known as oxidase test, positive, except Serratia, and this test is variable in Staphylococcus maltophilia. Why I am telling that? It's because when we identify as a bacteria, we perform an oxidase test for non-fermenters. Pseudomonas give this test positive. So all these non-fermenting bacteria can be misidentified as Pseudomonas species also, if the identification is not confirmed by MALDI-TOF. All these pathogens are of low virulence also, but they can be opportunistic pathogens and may cause severe infections in immunocompromised patients. Then all these bacteria are colonizers of hospital environment. For example, they can colonize water supplies, ventilators, and even disinfectants, like chlorhexidine, Pseudomonas, which has been activated for chlorhexidine solution. Next, we start with Pseudomonas species. Coagulase has already been discussed by Dr. Rath. So I will start with Pseudomonas maltophilia. We can see in the chart that the distribution of this species from various wards from the hospital. We can see the maximum number of cases were from emergency ward, followed by hematology, followed by anesthesia, nephrology, and others. A total of 81 isolates of Pseudomonas were identified. Coming on to the antimicrobial susceptibility of these isolates, out of total 81 isolates, 100% sensitivity was seen for levofloxacin, for minocycline, followed by cotrimazole and chloramphenicol. But picatin's flavulanic acid was the isolates were resistant to picatin's flavulanic acid, of 52%. In the literature, it has been mentioned that the treatment of choice for Pseudomonas is cotrimazole, fluoroquinolones, and minocycline. And from our antibiogram also, we can assume that these agents should be working fine. But all these data are derived from in vitro studies only, and more studies are needed to justify the in vivo efficacy also. Coming on to the next pathogen, which is Serratia marcescens. We identified almost 18 Serratia isolates from different wards, and we can see in the chart that maximum isolates were from emergency and general hospital. There were 3 isolates each from these wards, followed by surgical gastroenterology, nephrology, immunology, and gastroenterology. From there, we isolated 2 such species each, followed by pediatric surgery, medical care. Coming on to the sensitivity of these isolates from blood perspective, out of total 18 isolates, we can see that maximum the 100% sensitivity was for imipenem, followed by ceftazidime, ciprofloxacin, ertapenem, and virotex. And this was followed again by amikacin and cotrimazole and ceftazidime. In the literature, it has been shown that Serratia species respond well to aminoglycosides, cotrimazole, fluoroquinolone, and carbapenem with multidose species are found. So we can see that imipenem works well, and followed by the fluoroquinolone and cotrimazole. Coming on to the next pathogen, which is Acinetobacter. You can look at the chart on the left side. There, it shows the distribution of Acinetobacter species from this ward. And as we can see, maximum number of cases were from emergency, followed by CTDS and other wards. Then there are there are two species which we encountered for this genus. Achromobacter xylooxidans were 7 in number out of total 11 isolates, followed by Achromobacter denitrans, which were only 4 in number. Coming on to the Ochrobacterium species from different wards, we can see the chart that the maximum number of isolates were from pediatric gastroenterology, followed by emergency, followed by gastroenterology and nephrology. A total of 15 isolates were encountered, and 2 species were found. One was Ochrobacter frequently, which were 13 in number out of total 50 isolates, and Ochrobacter anthropus, which was 3. The maximum were Ochrobacter. We will be looking at the antimicrobial susceptibility patterns of these two together, because the agents which we put up during antimicrobial testing are same for these patterns. So, if we look at the blue column, which shows the sensitivity of Achromobacter, we can see that out of 11 Achromobacter isolates, maximum sensitivity was seen for agent cotrimoxazole. All the 11 isolates were sensitive, followed by other agents like piperacillin-tazobacter combination, levofloxacin, and ceftazidime, followed by imipenem and aeruginosa. So, carbapenems are down the line. In the literature also, it is mentioned that Achromobacter species respond well to ceftazidime, piperacillin-tazobacter, and they have been mentioned as treatment of. But from our data, we can see that cotrimoxazole works fine. Next, Ochrobacter. We can look at the orange columns now, and we can see that out of total of 16 isolates, all the isolates were sensitive to carbapenem and cotrimoxazole, and this sensitivity was followed by levofloxacin, followed by other agents. In the literature also, it has been mentioned that fluoroquinolones and cotrimoxazole work fine for this agent. And from our data, it is evident only that carbapenem, cotrimoxazole, and fluoroquinolones should be working fine. Coming on to the next pathogen, which is Ralstonia. If you look at the chart for distribution, a total of 14 Ralstonia isolates were identified, and maximum number of isolates were from hematology ward, followed by endocrinology and emergency, from where we recovered 2 isolates, followed by others. The 2 species of Ralstonia genus which we isolated were Ralstonia manitolinitica and Ralstonia piqueti. Majority were Ralstonia piqueti, which were 8 in number out of 14 total isolates, and Ralstonia manitolinitica were only 6. Coming on to the next pathogen, which is Rhizobacterium. We can see here that we isolated a total of 9 isolates of Rhizobacterium species, and maximum from majority of them were from CCM, followed by anesthesia. From CCM we got 8 isolates, and the distribution of Rhizobacterium species was maximum were Rhizobacterium indologenes, which were 8 in number, and followed by Rhizobacterium CS, which was only 1. Coming on to the sensitivity patterns of isolates, we can see that if you look at the blue column which shows the Rhizobacterium, we can see that out of total 9, the maximum sensitivity was seen for doxycycline and phenolcycline, followed by cotrimoxazole. Again, for Ralstonia, which is shown by orange column, we can see that out of total 14 isolates, the maximum sensitivity was seen for phenolcycline, levoperazole sulbactam combination, followed by cotrimoxazole, followed by levofloxacin. And in the literature also, it has mentioned that for these agents, the treatment of choice are fluoroquinolones and cotrimoxazole. Coming on to the next pathogen, this Elizabeth species. We have isolated around 8 such cases, and a maximum were from anesthesia ward, 15 number, followed by emergency, and followed by neurology, from where we got 1 eye. Elizabeth one was Elizabeth meningoplectica, which were only 3 number, while the majority was constituted by Elizabeth singly and office, so 5 in number out of a total 8. Coming on to the antimicrobial susceptibility pattern of this disease, we can look at the chart and you can see that out of total of 8 isolates, actually sensitivity was seen for aeruginosa, piperacillin-tazobacter combination, followed by doxycycline, cotrimoxazole, followed by others. And in the literature also, it has been recommended that we should give a combination of piperacillin-tazobacter plus cotrimoxazole and fluoroquinolones. So when we look at the chart, we know now that these pathogens respond to the older antibiotics like doxycycline, chloropyrrolone, and cotrimoxin. So these non-fermenting gram-negative bacteria are an emergent one and becoming a growing cause of severe infection. Most of these infections, as I already discussed, are misidentified as Pseudomonas through confirmation to that by Marketov. Then these pathogens frequently colonize many of the fluids used in hospital settings, like saline, invasive medical devices, which may become a vehicle to bypass normal hospital defenses and thus they can enter the hospital. So practicing hand hygiene can go a long way with infections and use of steady spectrum antibiotics, which to select on these pathogens should be the use of antibiotics should be justified. Also, when we hear about gram-negative bacteria, we think of colicin and carbapenems in our mind. But colicin cannot be used to treat these infections because they are intrinsically resistant to colicin. And older antibiotics like chloropyrrolone, cotrimoxin, doxycycline have shown good efficacy. So antimicrobial stewardship can go a long way in combating rise of these pathogens. With this note, I end my presentation, and I would now like to invite Dr. Chinmay sir for presenting the next. Thank you.
Thank you, Didi. Good morning to all. So this was all about the uncommon gram-negative bacteria. I will be covering about the common gram-negative bacteria. We are living the world of paradox because we have already seen that these bacteria, uncommon bacteria, they are resistant to the extended spectrum antibiotics like colicin and carbapenems, so they are increasing. However, the common antibiotics, the common bacteria like Klebsiella, E. coli, they are resistant to the older bacteria, older antibiotics, and they mainly respond to the last line antibiotics like colicin and carbapenems. So, I will be covering about the antibiogram of commonly isolated bacteria, our data. So, in the last year, 2022, the bacteriology, we received about 77,006 samples. As you can see, majority were around 50% or half, more than half were urine, followed by blood sample around 26%, and 10% were pus. Pus, it covered all the samples like infected and non-infected, also sterile fluid like pericardial fluid and blood fluid, like that, and 9% were sputum or other respiratory samples like TT aspirate, bowel fluid, and sputum also, and 2% was around. So, talking about the culture positivity, how much of the different samples came positive for culture, we can see that around 20% of urine samples were significantly positive, and 79.8% were either sterile or non-significant or contaminated. And among the pus samples, we can see that around 65%, because we can expect that 65% of the pus samples were significantly positive, and around 35% were sterile. Talking about the sputum, 53% were culture positive. Culture positive, I mean that it is significantly culture positive, and 47% were either sterile or no pathogenic organism were seen or non-sterile, because sputum normally also contains normal oral bacteria. Among the blood sample, we found around 15% positivity of the culture positivity among the blood samples, and around 85% were sterile. Also, the literature suggests that around the blood positivity is around 10 to 20% of the total sample. And CSF, around 6% positivity was seen, and 94% were sterile. So overall, we can say that around 31.8% of our samples were culture positivity or significant, and around 68% were non-significant or sterile. So talking about the different gram positive and gram negativity, because both the broad headings, they differ in their epidemiology, their pathogen, their antibiotic sensitivity. So we can see that 71% were gram negative, especially from the urine samples and the respiratory samples, and around 29% were gram positive, mainly Staphylococcus, Coagulase, Staphylococcus, Enterococcus, and they were more from the blood sample, bacteriemia cases, and also the pus sample. So, talking about the bacteriemia or the blood sample, so you can see that coagulase negative Staphylococcus forms the majority of the isolate, around 23% coagulase negative Staphylococcus, 23%. But it is, we cannot say that whether it is significant or non-significant because coagulase negative Staphylococcus is a normal skin contaminant. So, a single isolate of the coagulase negative Staphylococcus cannot denote its significance unless we isolate it more than 2 times or in different sites of the peripheral vein or central vein or 2 different sites of the patient's body. But it can cause severe infection, especially in immunocompromised patients, also patients having the prosthetic implant and prosthetic valves and the intravenous device. So in this it can form a biofilm and it can cause infection in there. So both it can be contaminant or it can be a pathogen. The other gram positive like Staphylococcus aureus, it is a pathogenic organism. Even a single isolate is significant. So we isolated around 9% of the Staphylococcus aureus. Among the gram negative, Klebsiella pneumoniae is the major pathogen, around 22%. Klebsiella pneumoniae, followed by E. coli, 13%. Other non-fermenters like Pseudomonas, aeruginosa, 10%. Acinetobacter bovinae, around 7%. We isolated. We found that among the bacterial samples, we also found Candida species. Around 5% of Candidemia cases we also found a significant cause of morbidity and mortality, especially in ICU. So, talking about the Staphylococcus species, you can see that around 68% were coagulase negative Staphylococcus and 32% were Staphylococcus aureus. So, as I have already mentioned, a single isolate of the coagulase negative Staphylococcus is not significant unless the patient is very much immunocompromised or prosthetic implants has been there. So I urge the clinician or the colleagues to send multiple samples if they encounter the coagulase negative Staphylococcus in their patient. Among the urine, we found that because majority of the UTI they come from the outpatient setting, OPD setting, and the E. coli is the major cause of the uncomplicated cystitis cases. So we found around 42% of UTI cases was due to E. coli. And among the other hospitalized patients or catheter UTI, we found that Klebsiella pneumoniae around 19%, and gram positive like Enterococcus is around 15%, and other gram negative like Pseudomonas aeruginosa 11% and Enterococcus mysterium 5%. Among the first, we can see that the E. coli is the major pathogen around 25%, and it is more in especially in gastro patient and surgical gastric patient. E. coli because E. coli and the Enterococcus they are the major pathogen to surgical patient because they are normally inhabitant of the GI system. So, like 25%, then Pseudomonas aeruginosa 15%, then Acinetobacter bovinae, Antibiogram Klebsiella pneumoniae around 14%, and other gram positive organisms like Staphylococcus aureus and Coagulase negative Staphylococcus. Here I want to reiterate that Pseudomonas aeruginosa is a major cause of ear infection. Especially we found around 80% of the Pseudomonas aeruginosa cases are found in the ear first case, ear infection. And Staphylococcus aureus we found in majority cases of endocrine surgery, especially in the breast abscess cases we found Staphylococcus aureus. So these are the main pathogens to clinical clinic. Among the respiratory samples, we can see that Klebsiella pneumoniae is a major pathogen, around 50% of Klebsiella pneumoniae, and followed by the Acinetobacter 59%. Sometimes we can find that mixed infection can be seen in especially in TH spirit samples and DTH spirit samples. We can find both Klebsiella and Acinetobacter or Pseudomonas or Acinetobacter mixed infection we can see. So after Acinetobacter, Pseudomonas aeruginosa 22% and E. coli also 8%. In this case, the majority were gram negative organisms and gram positive like Staphylococcus aureus and others were very less, 3 to 4% were encountered. So after the epidemiology, you can see the sensitivity to most common antibiotics. We have compared our data with the ICMR data. The ICMR, they compiled the data from 20 different centers all over India, and with nodal centers in Delhi, Jimbar, Pondicherry, Vijay, Chandigarh, and the CMC Vellore, and they compiled their data, and we can see for the most common pathogen, the Klebsiella pneumoniae, we can see that the ICMR data showed that 96% were sensitive to cholesterol, and our isolate also 92% were sensitive to cholesterol. So our data is comparable to the ICMR data. Other, we can see that among the carbapenems, the Klebsiella around 30% and 26% are sensitive to imipenem and meropenem, which is around 46% of the ICMR data. Among amikacin, our isolates Klebsiella 30% were sensitive, followed by levofloxacin 26% and piperacillin tazobactam around 36%. So as cholesterol is also, our data is comparable to the ICMR data in cholesterol cases, and other carbapenems and amikacin and levofloxacin slightly lower than the ICMR data. And one reason may be that because they have more OPD cases, more outpatient cases, they encounter more community-acquired infections. Like they have more pediatric cases, OPD, more gynec OPD than general medicine cases or general orthopedics cases. So in their centers, the community-acquired infections are more. So maybe they are typically slightly more than in our. Among the E. coli sensitivity, we can see 2% of our isolates are sensitive, better than Klebsiella pneumoniae, followed by the carbapenem, around 62% and 50% of imipenem, meropenem were sensitive. Similar to 54% and 69% of ICMR data. Amikacin around 58% were sensitive as compared to 78% of the ICMR data, followed by piperacillin tazobactam around 52% and levofloxacin around 19%. Among the Pseudomonas aeruginosa cases, you can see that also cholesterol, 97% of our isolates were sensitive to cholesterol, and followed by carbapenems like imipenem 60%, and meropenem also comparable, around 60% of meropenem was sensitive. And among aminoglycoside, amikacin was 60% sensitive. In this case, we find that ceftazidime also was very good. Not ceftriaxone, but ceftazidime was very good against the Pseudomonas aeruginosa. Around 50%, more than half cases were sensitive to ceftazidime. And among the fluoroquinolones, the levofloxacin around 51% and piperacillin tazobactam around 52%. So in Pseudomonas, although it is a major cause of hospital-acquired infection, the sensitivity is better than the other Klebsiella pneumoniae and E. coli. Among the Acinetobacter species, it is a major cause of, although it is virulence, not very much described, but we found that its resistance is very much high. Both the ICMR data and our data showed that it is around 4% to 14% of our isolates, and the ICMR data showed that it is sensitive to carbapenem, by levofloxacin 15% and 13%, around 19%. So the major antibiotics like fluoroquinolones, aminoglycosides, and the carbapenem, they are the isolates, they are resistant. But we can see that it is very much sensitive to cholesterol. 96% of our isolates to cholesterol by minocycline for Acinetobacter species, especially in OPD basis like the oral drug. So can be given for Acinetobacter. 70% of the isolates are sensitive to minocycline. Among the Staphylococcus aureus, fluoroquinolones around 29% isolate as compared to ICMR data around 17%, 29% is sensitive in our data. Micin around 47%, similar that 40. Almost all are sensitive to frequently. Around 100% sensitivity was seen to the both these antibiotics. Gentamicin usually give both ampicillin plus gentamicin to enterococci around 40% to ampicillin. The glycopeptides, around 84% of the vancomycin was the antibiotic. So, what about the sensitivity to second line antibiotics? Our data showed that cholesterol sensitivity, Pseudomonas aeruginosa, both are only 100% and 97% were sensitive to this. And Acinetobacter pneumoniae sensitive to Klebsiella pneumoniae bacteria, they were sensitive to cholesterol. So, but we have seen that the uncommon pathogens they are resistant to cholesterol, but the common pathogens to the cholesterol. Of the phosphomycin, because we know that phosphomycin is a very good oral drug for to treat the UTI cases, the urinary antibiotic. Majority of the E. coli, around 98% were sensitive to phosphomycin. It's good for the oral for OPD basis of UTI. 28% of the Klebsiella pneumoniae were sensitive to the phosphomycin. For Pseudomonas aeruginosa, the sensitivity is slightly less, around 71% of the Pseudomonas aeruginosa cases sensitive phosphomycin. Among the minocycline has been emerged now a choice for treating the MDR cases, especially for Enterobacteriaceae group, E. coli, Klebsiella, and gram positive also. In MDR cases, many centers are using minocycline to MDR work. So, E. coli were minocycline, followed by Klebsiella around 73%. We are not encountering any VRSA cases, vancomycin resistant Staphylococcus cases, or the high number of VRE cases. Just suggesting our data also showed that around 100% of the antibiotic so oral drug can be meningitis cases also, because for meningitis cases our data 100% MRSA isolate were sensitive to planet. Also in VRE cases around isolate vancomycin resistant enterococcus, they were resistant to the T-cycline is indicated only for the skin and surface infection and also the intra-abdominal infection, and it should not be given in bacteremia cases, also in the meningitis cases. It is only indicated for intra-abdominal infection and skin and surface infection. Acinetobacter species. By E. coli, around 87% of the E. coli and 7% were sensitive to. So, we have made the year-wise trends in MDR cases. Our data showed that although the resistance is high, but the past decade the resistance to bugs has been stable in the incident. You can see that the MRSA cases, they are more or less stable around 55% in 2010 and the Indian data showed that it is 50. Carbapenem resistant and Acinetobacter, although it is very high, was reaching it was 74%, now it was 60 to 90%. Also the pan Indian data shows that or around only 10 to 15% of the carbapenems works against the Acinetobacter. The vancomycin resistant Enterococcus species, it is also more or less stable around 13% of the resistant cases. It is around 70 of vancomycin we are encountered. For polycystin resistant Klebsiella pneumoniae also 2016 to 7%. Now we are seeing. For the carbapenem aeruginosa cases, resistant to the carbapenem. So, put some new antibiotics. First, I talk about the Staphylococcus avivectum H2N. Avivectum is a non-beta-lactam bitter FDA in 2015 and indicated for all the ESL producing bacteria and opsa producing bacteria. The metallo-beta-lactam producer, it does not act against which producing bacteria like NDM producing bacteria. So it can be combined with H2N to cover the all beta-lactamase producing bacteria. So beta-lactamase and with the major beta-lactamase producing bacteria. But hepatitis avivectum, it will cover the ESBL organism, the ABL organism. So in complete, all the centers they are trying to prove its efficacy. But the cost is a major factor in selection of the antibiotic. We have done this study. In our assay, in the pneumonia, you can see that apart from polycystin, which is around 90, the avivectum alone was sensitive around 40%. When we combine with NM, the sensitivity goes to around 70%. H2N. Pseudomonas, you can see that apart from cholesterol, it is 97. Avivectum around 40% pseudomonas, and when we combine with H2N, goes to around 70%. Two antibiotics can create polycystin. Antibiotics ceftriaxone sulbactam EDTA, it both the beta-lactamase inhibitor and the metal. Which the metal is that the ion chelator EDTA it inhibits the metallo-beta-lactamase enzyme, which has zinc in their active site, so it activates the metallo-beta-lactamase enzyme of the bacteria. Meritog is ceftriaxone and between General of India. All infections like sepsis cases. What we tested, our data showed that it is comparable to, in cases, comparable to the one is the aureus or the one is the polycystin. This is the Enterobacter. So the MBL cases, right one, also the orange one, report. Streptococcus is a fifth generation cephalosporin mainly indicated for gram-positive bacteria, for gram-negative bacteria. It is approved by US FDA for skin and soft tissue infections for pneumonia, especially MRSA. MDR gram-positive only for gram-negative. For sepsis and other infections for its efficacy. When we tested, our assay showed that around 89% of our MRSA were sensitive to ceftriaxone. Marcons were also sensitive. As alternative to vancomycin, because some renal failure patient or renal toxicity patient use vancomycin, so we can use. Another is levonorephoxacin is novel antibiotic. It is a novel fluoroquinolone antibiotic. It is a activity against mainly against the main positive features was that it can be given both IV and oral form, and bloodstream infections, and it can be alternative to vancomycin lineage. We tested all our gram-positive isolates like type aureus, corn, and they all were sensitive to the levodopa fluoxetine, which we did not find any resistance. These are these, as we have already discussed, these are some intrinsic resistant cases. Isolate these bacteria, these drugs should not be given because they have already the intrinsic resistance even before the administration of any antibiotic. So, these bacteria, when isolated, the antibiotics should not be given, like Burkholderia for cholesterol, then Staphylococcus, carbapenem, Pseudomonas, diacycline, and tapenem, and Proteus coli. For gram-positive, we also Antibiographically, first and second generation cephalosporin should not be given. So, these are all these are the few of our publications. The publication last year. So, to summarize, antibiotic resistance is a major problem of concern, especially in gram-negative bacteria. And majority of bacteria are sensitive only to few antibiotics like cholesterol, diacycline, and fosfomycin. This is not only our data, also the pan-Indian data, also even in the old world, this is a major problem. And even resistance mechanisms to these new antibiotics are also developing. So the antibiotic stewardship is the need of the hour in our world. Thank you.